Now, I'm honored to invite a very extremely distinguished scientist and clinician who has done and he has many patents. So the talk is very interesting, like what we are looking for the best result in vitiligo, how we can achieve, how we can optimize these combination therapies. Dr. Thierry Passeron.
Thank you very much, Davinder. Thank you for the invitation, and thank you all for assisting to this last talk. So it's my pleasure to talk about this. I think it's a very important topic because we're going to see that, at least to my opinion, the future of vitiligo treatment must rely on combination approaches. So these are my disclosures. And we discuss a lot of vitiligo. The key question here is, why do we need combination approaches for our vitiligo patients? And in fact, the first answer is that at the difference, for example, of psoriasis, when you target the Th17 axis, you get very nice results. But in vitiligo, we need to achieve different goals. The first one is to halt the depigmentation. And to do that, we have to halt the melanocytic loss. And so far, the best way to do that is to act on the immune response. However, and this is something that is very different from other disorders, is that in vitiligo, you also need to induce the repigmentation. And we can see in the patient, most of them are starting to depigment on the face and the hands, but when it comes to the repigmentation, this is not the same. The face is repigmenting much better, and the hands are very, very difficult to repigment. So this is two kind of processes. And in fact, to induce repigmentation, in the biology, what we need to do is to induce the differentiation and then the proliferation of melanocytes. And this process, whatever the treatment we have, at least so far, takes a long time. And we have to explain to our patient that it's a long process that takes 6 to 24 months. Then, ultimately, we have to prevent the relapses because so far, all the patients are relapsing about 40 to 50% of cases. So different kind of objective and so probably different kind of therapeutic approaches. I won't go too much into details, but I would like to tell you about the pathophysiology because we heard a lot of talks, and in fact, we know that in vitiligo there is, of course, this genetic predisposition, and you can see that most of the genes are related to the immune responses, innate or adaptive. And there are also a couple of genes that are specific from melanocytes. However, in vitiligo, and we heard very nice talks here, that clearly demonstrating that in vitiligo we have also skin abnormalities involving not only the melanocyte but also the keratinocyte and fibroblasts. There is a key role, and it's well demonstrated, on the oxidative stress and increased production of radical species. There is this senescent secretion that Professor Picardo nicely demonstrated, but there's also this mitochondrial alteration and also some extracellular matrix protein release. So clearly, the epidermis of the vitiligo patients is clearly altered. Thanks to the work of the Borgodo group, it's also known that there is this flying melanocyte, this melanocytorrhea. You see those melanocytes that should be attached to the basal membrane that are going up in the upper epidermis. And this is due to the decreased E-cadherin expression, and it has been shown that at least interferon gamma and TNF-alpha induce this melanocyte detachment through E-cadherin disruption by the increase of MMP9. Few years ago, we demonstrated in the lab that in vitiligo, the innate response is very important, and vitiligo patients have increased sensitivity to internal and external stress, bumps, damps, etc. And we also demonstrated that melanocytes have a specific receptor called 6L3B that is very sensitive to 6L10 and then induce the apoptosis of melanocyte. And the remaining ones are expressing their own antigens, so when the T cells are coming, they are attacked by those immune cells. And so this study emphasized the key role of the immunity and also in the melanocytes themselves in the initiation of vitiligo, and also suggesting that targeting 6F3B could be a very interesting target because it's very specific of melanocytes. And recently with Mary and with my friend from Bordeaux, we tried to summarize all the data we have on the innate immunity. And in fact, the innate immunity is making the bridge between this genetic background, these environmental factors, bumps, dams, etc., that stimulate the innate response. And this innate response will activate the specific adaptive immunity. And I won't go into details, but you can see that all those red arrows are potential targets that we can try to use to halt vitiligo progression. And I was talking about stress, and in fact, when we're talking about stress in biology, we are talking about pathogen-associated molecular patterns and damages associated molecular patterns. And we and others have demonstrated that in vitiligo there is a gut and skin dysbiosis, and also in the cells. So the dams, you have these UPR, but also oxidative stress, autophagy that is altered. So those are all targets that we can use for helping our patients with vitiligo. And of course, but you see that it's not the only pathway. You have at the end this adaptive immune response, including these interferon gamma JAK-STAT 6 and 9, 6, 8, and pathway, that's for sure is playing a key role in the loss of melanocytes. But as you can see here, we are talking about the disappearance of the melanocyte. What about the repigmentation? And I'm not talking when melanocytes are still there, because you're stopping the immune process and the remaining melanocyte can proliferate. I'm talking about areas completely devoid of melanocyte. So here you have to induce the differentiation of melanocyte stem cells. And here we demonstrated 7 years ago already that the Wnt pathway is decreased in the skin of vitiligo patient. And very interestingly, the Wnt pathway has a key role for inducing the differentiation of melanocyte stem cells. And we go further. We took, here you can see it's ex vivo skin. So we took skin from patients with vitiligo on lesional area. And then we treat them with Wnt agonist. And you can see here that within 15 days, we were able to induce the differentiation into pre-melanocyte, meaning that it's able to induce this differentiation. And I would like to emphasize this point because we commonly heard that, oh, there is only the melanocyte stem cells are in the hair follicle. Of course, this is the main reservoir, and this is the one we know the better because it's the one that is easy to target with phototherapy. But it's well demonstrated that we have melanocyte stem cells in the sebaceous gland and in the dermal skin, glabral skin. And those are always there, even in very late vitiligo. So if we are able, by using Wnt agonist or other pathway, to stimulate, that will be a very useful tool to induce the repigmentation. And I'm thinking about the knees, the extremities or the fingers that are very difficult to repigment. And the other thing is that we have no treatment so far that provides truly satisfactory results in most cases. I just remind you the results of the JAK inhibitor, the ruxolitinib cream. It's effective, but you can see here that in monotherapy, if we are looking at facial, so the best and easier parts, at 1 year of treatment, only 1/3 of the patient achieve a complete or almost complete repigmentation. So this is good, and for sure when we combine, we'll have better results. But in monotherapy, this is not fully satisfactory. And I present you yesterday the result on the body area. And you can see that in some areas, such as head, neck, and trunk, and upper or lower extremities, we can achieve some good result, but on hands and feet, it's really difficult. And you can see that this result is after 1 year of twice daily application of the cream. What about systemic treatment? And so far we have the result, for example, for ruxolitinib, so a JAK3 TEC inhibitor. Of course, it's a phase 2b study. Professor Pandya showed you yesterday. Just wanted to emphasize. After 6 months, you can see that the results, and there is some significant differences between the placebo and the highest doses of reticulocytinib, but you can see that it's only 20% of improvement, and after 1 year, it's getting much better. However, if we are looking at the T-VASI, the repigmentation all over the body, I have to say that if you compare this repigmentation, even higher dose, as compared to the placebo, I have to say that I'm not so impressed. So probably there is many things that we can discuss, maybe long-term treatment, we'll see. But so far the tolerance is good, but the results are not that impressive. And I think that probably it's because it's in monotherapy. And I like this very short retrospective series, but using tofacitinib, so pan-JAK inhibitor. And they reported repigmentation in half of the cases, but the repigmentation was observed only in patients who received UVB or were exposed to the sun. And also, very interestingly, they look at the CD8 in the lesions, and mostly the patients who have this increased CD8 have better response, meaning that if you have the immune activation, for sure, targeting this immune part will be more beneficial. But for sure, when you combine this immune treatment with stimulation of the repigmentation, for example, UVB, you have better results, meaning that it's probably very interesting to combine therapy. And you see here one example of narrowband UVB and oral mini pulse, and you can see, of course, it's an open label study, but in 100% of cases, they show a progression arrest within 12 weeks, and 40% of the patients achieved 50% of repigmentation after 12 weeks. And Dr. Pandya nicely demonstrated that combining narrowband UVB and oral mini pulse is probably the best thing we have so far for treating the very active form of vitiligo. So what about combination of phototherapy and topical steroids? In fact, the first one who proposed this was Thierry Passeron in 1999, and he nicely demonstrated in a prospective randomized control left-right comparison study that if you combine UVA and topical steroids, it's getting better result as compared to UVA or topical steroids alone. And we have to wait more than 10 years to get the same result with topical steroids and UVB. And almost 17 years ago, and that's difficult for me because it was one of my first study, and we demonstrated that combining excimer laser with tacrolimus ointment provides significant better result as compared to the laser alone. And of course, if you're looking in area such as the face that are responding much better, the difference is there, but it's not that high. However, in difficult to treat areas such as bony preeminence, knees, elbows, you can see that combining treatment provides much better results as compared to laser alone. You see one example on the knees, and of course on the face it's always easy, and here after only 15 sessions you can see this very nice fully repigmentation. And those data that we published many years ago have been now confirmed by many others, and we have even meta-analysis, and you can see that if you combine, here you have the result with tacrolimus or pimecrolimus alone, and here when you combine with UVB, and it's well demonstrated that you get much better results if you combine those topical treatments with phototherapy, no doubt about that. And in fact, this combination approach is not only for medical treatments. For surgical therapies, already in 1983, it was demonstrated that if you follow the graph, the skin graph by your PUVA, you get better results. And now we know that after transplantation of cellular suspension, followed by narrowband UVB or PUVA, it's getting much better results than phototherapy or grafting alone. And there was less data, but also topical steroids seems to enhance and to provide better results of surgical grafting if you provide topical steroids and also low dose of oral steroids that can maybe also be beneficial after surgical procedures. It's only open series and one case report. And this is not the only way. I like very much this study from Professor Taga Ambar, that we all miss him. And he made a very nice prospective intra-individual comparative study in 50 patients. You see, it's very difficult to treat area. And he combined erbium laser plus 5FU and UVB as compared to UVB alone. And you can see that there was significant better results in the combination approach as compared to the UVB alone. And many years ago, we do also a prospective randomized with intra-individual comparison, only in difficult to treat area. And we compare UVB and topical steroids, with UVB topical steroids preceded by a full laser assist dermabrasion. And I can tell you that I never saw better result than this. You can see here the results, for example, in the hands. This is with an urban UVB and topical steroid, and here exactly the same on the other part of the hand with this dermabrasion. Here, this part was dermabrased and this part not. So it was very nice. The problem is that we have a lot of side effects. The pain, delayed healing, 2 hypertrophic scars. But what was quite interesting is that you see this patient has this hypertrophic scar, but she wanted me to do the other side. I say, no, you have this side effect. I say, I don't care. I don't see my vitiligo anymore. So I don't know. We are not proposing this kind of approach because of the side effect, but there's something there, some factor that has been released after the dermabrasion that probably stimulate the repigmentation in this difficult to treat area. And the same type of approaches have been reported by using fractional CO2 followed by UVB. You can see that the results are less impressive, but the tolerance is much better. And you can see that on the area treated with the laser, it's provide much better result as compared to the UVB alone. And since this initial study performed by Korean colleagues, it has been reported by other groups with sun or UVB that indeed fractional ablative laser can enhance the repigmentation after sun or UVB exposure. Alpha-melanotan was reported already 7 years ago. Alpha-melanotan is an MC1R agonist. There was a prospective randomized trial in 3 centers in USA. Skin type were 3 to 6, and you can see that the results in terms of the decrease of depigmentation, the increase of repigmentation was significantly better when you combine UVB to alpha-melanotan as compared to UVB alone. Again, as I was explaining yesterday, it can be only working on already differentiate melanocytes, so you need to differentiate them by using UVB. And there are some side effects, and one of the most important side effects is the hyperpigmentation of the skin. So probably there is an interest, but in combination with UV and only in dark skin individuals, which is already a good thing for all those patients. And we are talking about supplements and about oxidative stress. And there is a lot of data demonstrating the role of the oxidative stress in vitiligo. The problem is that if you're looking in literature or if you're trying antioxidant in your practice, you will see that most of them are not working, because not all the antioxidants are the same, and most of them are not absorbed. And we use this kind of antioxidant that's been demonstrated is they are protected from the gastric destruction, and they have been demonstrated to be delivered to the cells. But we made a prospective randomized double-blind placebo-controlled study like we are doing for drugs. And we included 50 patients with widespread vitiligo, and we gave them this double dose of this antioxidant for 3 months and single dose for 3 months, combined with UVB or placebo plus UVB twice a week. And you can see here that, in fact, we were able to induce 2 times more repigmentation in the group combining UVB and this type of antioxidant as compared to UVB and placebo. And I have to say that I was even surprised by such results. And the good thing, but we were not surprised about that, is that the tolerance was just excellent. Last but not least, here's some results. You can see this patient with very widespread vitiligo. Here it's after only 6 a month of treatment. And now this lady is almost completely repigmented. Of course, there are some areas in the wrist and the extremities of the tip, the finger that are not repigmented, but she has repigmented all over the body. Same, another lady here, you can see on the face, of course, the results are usually much better, and you can see on the arms, but again, look at the elbows and the wrists, they are more difficult to repigment. And last, if you combine ruxolitinib cream with UVB, it's only preliminary data on 19 patients in the open label part of the ruxolitinib cream phase 2 who received at least 12 weeks of UVB after receiving ruxolitinib cream alone. And you can see that there was this very nice improvement in most of the patients. And you can see this patient from Dr. Pandya, how he's getting better after the ruxolitinib cream was associated with the UVB. So it's very encouraging for the future, and of course, this needs to be confirmed in a larger study, but I do think that there is a room and probably a need for combining JAK inhibitors orally taken or topically applied with narrowband UVB to provide better results and quicker repigmentation. So very rapidly, the perspective. To my opinion, you can see here that JAK inhibitors are only the first phase. It's, of course, that will be interesting, but I do think that in the near future we'll have other treatment, other targets that could be used. We can try to use to target the dendritic cells. We can try to use the DAMs, the PAMs, trying to play on oxidative stress, on UPR, on unfolded proteins. We can try to, of course, work on CD8, but what about CD4 and NKs? The Tregs are also important. We can also try to prevent the detachment of melanocytes by using MMP9 inhibitor. We can also try to prevent at the beginning by using anti-CXCR3B blocking antibody, and finally also to enhance the repigmentation by using Wnt agonist or GSK3 beta inhibitors. So I think there's a bright future, and to my opinion, of course, there is a key role of the immune response. There's this CD8 activation for sure, but we don't have to overlook the other compartments such as CD4, Tregs, Trems, and innate cells. But it's not the only factor. We can also try to fight against the exposome factors when it's possible, to try to repair or to fight against the defective epidermal cells, and also either to bring melanocyte by using surgical procedure or directly to stimulate differentiation and proliferation of melanocyte stem cells. So really, I do think that only combination approach could provide optimal repigmentation in most patients in the future. Thank you very much for your attention. I just wanted, before to thank all this is our group in the INSERM, and you see Anen Bezouyesh, Claire Regazzetti, and Anya Malkovich who worked on some of the paper I showed, and of course Mary Tulik who is providing great work on vitiligo. And just I wanted to finish because this year I lost my mentor, Professor Orton. I think that you all know him. Well, I think we lost a giant in dermatology in vitiligo, and especially, and I do want to honor him here today. Thank you very much.
Thank you, Passeron, for an excellent overview on holistic approach to the vitiligo treatment. Yes, please. Mike.
If you have something to feel good and to avoid stress every day, I buy it. What I think is true is that we all experience some flares of vitiligo after being exposed to stress, a family or professional problem. But it's not the only stress. When I'm talking about stress, is stress in general. You are talking about oxidative stress. We are talking about UPR stress, we are talking about PAMS, so the dysbiosis, this morning Mary was talking about the isosmite. All of them are potential triggering factors. It's not that if you are exposed to one stress that you will have this flare, but on a genetic background, if everything is aligned, you will have this flare. So I don't think that we'll be able to live in the country or without any stress, or I will migrate there. But I think that we can try to act on those or to prevent as much as possible on those stress, or maybe it will be easier to identify the pathway that are activated after the stress and acting on this. And this is the innate part. When you have this stress, there are some chemokines that are released and activate the innate cells. And we demonstrated that in vitiligo, in the blood and in the skin, the innate cells are more responsive to the stress. So a little bit of stress will induce more response. And then we also demonstrated that melanocyte and keratinocyte of vitiligo patients are more susceptible to those cytokines. So a little bit of stress on a genetic background will induce the immune response. So I think it will be difficult to act on all those factors, but we have to keep in mind that we are knowing better the pathway, and if we can act on the beginning, oxidative stress is one of the possibility. I saw some very interesting data on UPR targeting compounds. I think those can be used, and I don't think it has to be used alone. We have to use it with immune-based treatment and also with therapies that are bringing or stimulating melanocyte regeneration.
Yes, please. Yes, please go ahead.
Oh, it is working. Thank you very much for that talk. That was really, really clear. I really appreciated that. I wonder about the GPSOD antioxidant. Is that available widely? Can you get that over the counter, like the polypodium and the ginkgo? How does it fit in?
In fact, it's not the polypodium. It's the SOD that has been gliadin protected.
Sorry, I know it's not. It's different, but can you get it?
Oh, you can get it. I don't know. It's available in many countries. I don't know in India, but I know it's available in China, in Europe, and in America. It's the company who sells that is Isocell, and you can find it on www.glisodin, so GLISODIN.com. And you can find it. I'm not saying that it's the only one. There are some, for example, with Palladium leukotomas, there was some data that were also quite interesting. I'm just saying that, and maybe combining, because Professor Picardo showed yesterday that there was different pathway, and I think that a cocktail could be good. I wanted to do just one that has very nice in vivo data, to see, okay, is it interesting or not? I was impressed by the result, but I think we can do better. We can do maybe a cocktail of antioxidant, but as I was explaining before, I do think because those treatments are not reimbursed, they are the cost. Of course, it's not the cost of a biologic, but we need to assess them as we are assessing drugs. So, but I do think that combining antioxidant could be very interesting.
Yeah. That's really helpful, actually. And one thing I thought I'd just mention, I don't know if you're aware of it, because we're involved in a trial for porphyria with the new MC1R receptor agonist, which is oral from Mitsubishi. So I don't know whether you've heard about that, but I thought that was kind of an interesting development.
I didn't know about that. I think it's very interesting, but it's the same, to my opinion, as alpha-melanocyte. As I was mentioning, MC1R is only expressed by differentiated melanocyte. So, to my opinion, that's probably helpful, clearly, but you have to combine with UV to enhance the differentiation, and also the good thing of UVB is you can also decrease because you have immunosuppressive action of the UVB. But if you can, for example, speed up the process of the repigmentation by 2 or by 3, that's great for the patients. Because you imagine that the patient and the cost to go to the phototherapy units or to buy a phototherapy unit, it takes time, it takes money. So if you can decrease this time, it's already great.
I also wonder whether the stimulation of the MC1R actually has an immunosuppressive effect itself, you know, beyond just provoking pigmentation, because obviously that's part of what happens when you expose someone to UVB. So I wonder about that, because we think that might be part of the reason why it works so well for porphyria.
There's some data, and I think that Marcus Baum shows some interesting data about this decreased immunity. And I think that it could be very interesting also. Honestly, so far I didn't see some very convincing data on the immune decrease by alpha MSH agonist in vitiligo in this immune part. But I'm not saying it's not because it's not demonstrated, that's not the case. So maybe it's just better, and you will see. Yes?
Yes.
Yes, no, I was just thinking about the fact that it's quite difficult to go to a UVB unit now, and it takes time and everything. So even with a new drug, we still have to associate both so to have better results.
It is at least my opinion. John, you heard him this morning, is convinced, maybe he's right, that if you are very active on immune part, you will have a repigmentation over the body. I don't think so, at least in all vitiligos, I don't think so, but it's just my opinion. But yes, probably you need to, you can use the sun, but it's only in some areas and in some season. You can also prescribe some UV lamps at home, but everything has a cost, and it's also very difficult for the patient. So one thing that can be done is to expose to the sun. And some patients are coming to me just because they are listening to some talks that are available on the internet. They just expose for the first time to the sun, and they're coming back, they're already a very nice repigmentation. They didn't repigment before because all the dermatologists and say, oh my God, you have vitiligo. Please go, never expose to the sun and use SPF 50 all over the time. So just that can be useful. But I fully agree that we are talking about very nice treatment. But I think that the discussion you had and we had together on the beginning of this afternoon about how to access to the physician and to the drugs are very important, and it's also different in different of countries. So I think that in France we are quite lucky for that, but people don't know. But it's very important to think about all over the people everywhere in the world. So yes, the sun is free for now, so that could be good.
Yes, thank you, Dr. Passeron, for your wonderful talk. The first question is about the Wnt agonist that they've proposed and repigmentation. Do you think it will work for the leukotrichia patients, because that's also another tough issue? And the second thing is when we are thinking about stimulating these melanocyte stem cells, but the Wnt pathway is also involved in cancers, melanomas, the migrations, the invasions. Is there a concern about the use of Wnt agonists in this instance? Thank you.
Those are two very important questions. And yeah, I do think that it's potentially possible to repigment the hair also, because I think it was a Korean group more than 10 years ago already demonstrated that even in leukotrichia you still have some melanocyte stem cells that are there. So we have to make them differentiate, which is more difficult for sure. The second part is that yes, I won't use a Wnt agonist systemically for sure. However, we demonstrated, and there's other studies that confirm that since, that in vitiligo lesions, and especially in some area, there is a decreased Wnt pathway. So the idea is not to overexpress Wnt, it's just to normalize Wnt. And I don't think we need to do that for months. In ex vivo, we need 15 days to induce in pre-melanocyte. Of course, it's always easier to put some Wnt agonist in the medium than to do, and we are actually working with pharmaceutical company to try to make those compounds to penetrate into the skin. So the idea here is just to ends this repigmentation. And look at, for example, the palm salt that are the most difficult one. We demonstrated 15 years ago that, in fact, the Wnt pathway due to DKK1 is decreased in this area. So I'm not thinking that it's explaining everything. Maybe there is other pathway, because Wnt is one of the most important, but it's not the only one involved in this differentiation. But I do think that we need to differentiate those melanocytes, and we cannot do that with MC1 agonists or those kind of drugs. We need to do something that can act on melanocyte stem cells, and there are not so many drugs or compounds that can do that.
Yes, I would just like to thank you very much, because really the presentation covered all what we think. So thank you, yes, in a very unbiased and perfect professional way. Thank you very much.
Thank you very much.
Any further question? So I mean, this Claddin protected superoxide dismutase, is it available in the market, or?
Yeah, it's available in the market in several countries in the world. I don't know from India, but you can look at on their website. I don't have any stock option, I can tell you, unfortunately, on this. So I'm not biased, but you can look at glysodan.com and find if they can sell it to you. I know that they are in China for sure. But again, I don't think these are the only one. I think that there are. But before using such supplement, I really think we have to test one of them, and maybe after to combine them. I like very much the scheme that Mau Picardo showed, because I think that if we can target many pathways, we get better results. Yeah. And really, I was impressed by the result. And to tell you the truth, I'm giving that in all my patients. Yeah. I'm saying, okay, if you can afford it, the first thing, the most important is the UV and then the topical treatment. But if you can afford, do this, because we know that it will be helpful.
Yeah. Thank you. Thank you.
Thank you.